Hello, this is Dr. William Sunstein of NSPC Spine and Brain Surgery. I'm going to put the spine first, actually, because we're focusing on spine today, but it's actually called NSPC, Brain and Spine Surgery. And I have my spine bro.
I'm Richard Obedient of Island Spine and Sports.
This is our 18th episode.
18 is a very special number.
Why is 18 special?
You know, the Jewish religion, 18 is chai, which means life.
This means life.
So, you know, when your kids have a bar mitzvah, a lot of the gifts come in multiples of 18.
That's right.
Whether it's $18, $36, $54, $180.
That's right. We always give that.
We like that number. It's one of the numbers of good luck. So we're hopefully gonna have some good luck in today's episode.
In the Chinese culture, apparently the number 8 is the good lucky
It's
number.
true. You know, when the Olympics were in Beijing, it started on August 8th, 2008, 888 at 8:08 p.m.
And that's a very lucky.
And that's it's a good omen for them. You know, if you turn eight sideways, it's infinity. It means riches.
That's right.
And I think somebody told me that the slot machines in China, Macau and Far East, instead of having 7s like they do in the United States, have 8s. 8 is their lucky number.
In fact, I remember when I used to collect wine.
You don't collect wine anymore? You still collect.
Well, I collected not the way I used to collect, but
it's different. What do you mean different?
Well, I mean, I'm saying they used to have. I used to have like wooden cases of wine, and on the side of a 2008 wine, it was a special edition.
Because the Chinese liked it, so they probably they raised the price.
They put an 8. They put an infinity symbol on the case to make the Chinese more interested in.
It's a marketing
buying it.
thing.
Exactly.
They're not stupid.
So here we are. We're talking more about.
There's a lot of money in wine.
There is a lot of money in wine, actually. I mean, and there's a lot of people that have a lot of money who buy.
Now, did you stop being a collector because you started drinking it all away, or you actually sold it? Or
No,
both?
I just
Combination.
I just don't know why exactly, but I guess I just had other priorities as time went on.
It's an investment.
It is an investment.
It's an investment of sorts. So.
I think the stock market would have been better actually over the last 10 years.
Depending on what you bought, for sure.
That's right.
Yeah.
But still, it is definitely something. If you know what you're buying, you can definitely get a lot of value out of that, and it doesn't tend to plummet in price.
What should we buy now?
What should you buy now?
I think airline stocks are going down because of what's going on in the war in the Middle East. So maybe.
Well, when the fuel thing gets straightened out, then maybe they'll go up.
Yeah, I'm sure it'll go back up.
Although
United, the airline and cruise lines, they're all probably plummeting right now because of what's the situation in the world. So it might be a bit. I mean, but they're not going to go up dramatically like Facebook and Nvidia did. You know, they're not going to have that tremendous growth.
I just use the Warren Buffett philosophy. You know, basically, be greedy when everyone's fearful, and fearful when everyone's greedy.
You're a contrarian.
But I think that's a good philosophy. And right now, everyone's fearful, et cetera, and things have plummeted. I think it's probably, if you are on a good timeline, I think it's a good time to buy.
So you like to buy on the dip?
I think it's, I think that's good to
Smart.
Use situations like this, like war or disasters, to basically
take advantage
of it.
but the question's always when it's dipping is, are you buying on the dip, or is it going to go even lower?
But you still bought it for sale.
You still got a discount theoretically,
right?
You know, but how long is it going to stay that low, and will it bounce back?
You can't time the market.
Those are all unknowns.
It's one thing.
So I just put in a certain amount every month and let the chips fall where they may. Don't think about it.
For all these young viewers, basically, with a long timeline, buy as much as you can, especially in situations.
Start
like
early.
This. Exactly.
Yeah.
All right. So therefore, that's our little investing advice.
We give investment advice as well as spine advice.
And we can talk about all kinds of things, obviously. So we have done 18 episodes. That's a long time.
Well, this will be the 18th episode.
Yeah. Well, we'll be doing that.
And one question that often pops up is when you talk to patients is, do you want to, especially when they have a neck problem and even a lower back problem, they'll go and they'll seek, especially in the New York area, they'll seek multiple opinions. And one person would say, I'll approach your problem from the front, I'll go from the back, I'll do both, front and back. so we can talk about the neck and the lower back because you can do front and backs in or anterior posteriors or anterior versus posterior
Or
in
lateral in the lumbar,
X
or,
slips,
or,
right? Correct.
or
Which is
posterior lateral
which is sort of
approaches.
like a pseudo anterior approach. So why don't we talk about that today?
Okay, I'm more than happy to talk about that because that is a big issue. People go see doctors and there's always multiple opinions. And you go to a spine meeting and you throw up a case and there's always many roads
It's
to lead
always
the room.
interesting.
Yep.
Yeah, and some people will say for sure you got to go from the front when there's a neck herniated disc, especially one herniated disc. But if you have multiple herniated discs, then the question becomes: should you go from the front or the back, or even both?
And the thing is, patients are always concerned also, in addition, is motion. That's a big thing that they say.
Motion is a big thing, and also there's a lot of fear when they go from the front of the neck about fear of losing their voice, having difficulty swallowing, eating. Those things all can become or a fear that patients have because not only are you in their spinal cord, but you're in their larynx and close to all the throat muscles and speech and swallowing can definitely be affected. So it's a concern. I mean, Steve, who was our I guess episode 16, who had the posterior cervical. We were originally going to do an anterior cervical on him years before, and then by the time I saw him, I changed my mind and said, you really have too many levels involved. So one issue I guess would be how many levels do they have when you decide to go front versus back? So let's start with that first. If you have at what point do you say you have too many level disease? I'd really feel better going from the back than the front.
I think that it depends obviously on the patient and certainly if their curvature of their spine. I mean, if the patient has
their lordosis versus their kyphosis.
Right.
So why don't you tell them what's lordosis and kyphosis?
If they have a front lordotic or basically curved forward spine, then that's favorable to a posterior approach. If they have multiple levels,
right. So if you have a normal curvature of your neck, that you're holding your head up and you're not kyphotic, which is when you're leaning your neck forward, then you're probably better off going you can go from the back without fear of hurting their lordosis or hurting their normal curvature.
If you
because
go from the
theoretically
back,
when you go from the back, you're going to make their lordosis worse. So usually you don't just do a laminectomy alone when you go from the back.
no, you want to prevent their
You got to
neck
do a
from
fusion at the same time.
developing a swan neck deformity in the future.
Right.
And basically, I mean, with the posterior approach from behind, you have multiple advantages. First of all, there's no vital structures when you're exposing.
Right. You're not worried about the trachea. You don't have to worry about the esophagus.
You
You're
just
not worried
have
about
muscle.
the carotid artery. Correct.
So that's one advantage. And then the other thing, obviously, is that when you have a patient with multiple level disease who's compressing their spinal cord, the spinal cord in a patient with a good lordosis tends to fall away from the spine after you've decompressed them.
The other thing I've noticed is that occasionally we just had this come up. We had a patient who had disease at C3, 4, 4, 5, 5, 7. They sort of skipped a level. So it almost makes more sense to go posteriorly in that situation because you really want to decompress everything.
Right.
And it's kind of odd to do an anterior cervical fusion at 3, 4, 4, 5, and then skip 5, 6, and then do 6, 7. So
right. Have a floating level.
Because that's just a situation where you're setting that level up to fail.
For the future.
There's going to be too much stress on that 5, 6
Right.
level, and eventually that's going to go.
So you just basically, you just say, I'm just going to decompress you, do a nice long segment decompression.
Right.
And you don't have to worry about the future for that, and you're accomplishing your goal.
Correct. Now, on the plus side, you don't have to deal with vital structures going from the back. But on the downside, it's a much more painful surgery because you're taking off a lot more muscle.
Right.
When you go from the front, there's only a small muscle, the platysma, which you're an expert on what the platysma does. It actually helps you move your neck forward, or when you lean your neck back to shave, that's what allows you to do
Right.
that.
So
But
that's
it's a very thin muscle.
very little tissue you have to go through. I mean, you really can sweep with your finger going down to the front of the
Correct.
spine without even having to disrupt much of the
There's
tissue.
not much dissection there, and I think a lot of the pain in spinal surgery comes from that exposure in posterior surgery, also in the lower back especially.
If you go from the front, well, one situation, obviously, if a person is kyphotic with a reverse curve, you really have no choice but to go from the front because by going from the back, you can, in essence, make the patient's compression worse.
Right, because you're going to make their kyphosis worse when you go.
You'll make them more
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 kyphotic.
kyphotic. If you decompress them, you'll lose those supporting structures from
Right. So
behind.
when you go from the front, you can actually, when you put the graft in, the graft is a little larger anteriorly, and that will allow for the lordosis to be maintained or to be corrected.
Right,
So
and
you can correct the deformity.
right, you can definitely correct the deformity. I mean, sometimes going posteriorly, you bring this. They say you bring the spine to the instrumentation you're putting in, so that sometimes helps also. But from the front, definitely you can establish a better
Now,
correction.
when you have sometimes we see somebody with multi-level cervical disease, and you think, they get multiple pain. Somebody says we go from the front, we go from the back. What do you do first? I generally like to go from the back first, because if they're relieved of their symptoms, maybe you don't even need
You
to
don't
go
even
from the
need to go
front.
from the front. You can always have that option, which is always important to tell the patient. We have the option in the future if we had to go from
If
the
you're
front.
if you're not getting better,
Right.
we can go from because it also depends where the compression's coming from.
Right.
Is most of the compression coming from anteriorly, or is it coming from posteriorly? That's another factor in the decision making as to
It also depends on what kind of pathology we're dealing with. Are we dealing with a soft herniated disc that's only compressing the nerve? Or are we talking about a big, chunk of bone that's pushing on their spinal cord from the
from a
front?
facet, yeah.
Because,
Or-
if you go from the front, I mean, we have a soft herniated disc. We obviously can easily remove that with an anterior or front approach.
Right, but if they have something called OPLL, or ossification, the posterior longitudinal ligament, where they actually develop bone, especially older patients,
Right.
it's more common for some reason in Asian patients as well. There's a lot of literature in Asian patients who are more prone to getting OPLL. And so then you got to think about going from the back. And in those cases, a lot of times a CAT scan is
Right,
better.
it helps you
is
understand
better
their
than
anatomy.
getting an MRI in terms of delineating what's actually calcified, what's bony, and what's soft.
Because sometimes that material is really stuck to the dural membrane, and you don't want to get a leak from the front because that's really hard to fix.
Yeah.
So
It's not fun.
you want to have that option of going posterior. Sometimes it's a gray area. Sometimes the patient's neck is a bit straight. It's not as curved forward, and it's not as lordotic. But sometimes you get just from experience, that you can get away with doing it posteriorly and
Well, I
get
think-
an adequate decompression.
I think once they're under anesthesia, the muscles relax a little bit, and then
Yes.
you can bring them to a lordosis.
You can get into a better
because they're in a
lordotic.
better position. Because a lot of times they're in a lot of pain, and so they stiffen up and they tense up, and they lose that lordosis because of that muscle.
Right, from
tension.
spasm. You get an X-ray of somebody who, after a car accident or something, that they note that the patient's in straightened lordosis.
Right. Loss of cervical lordosis.
Because of
Clinical
spasm.
correlation. That's what radiologists love.
Clinical correlation.
They love
is
to use that
required.
phrase.
Right.
They don't see a patient, so they can just say, well, it could be something bad. I think it's a cover your butt kind of a
Pretty much.
statement.
Yes, I know it is because
Well, you're married to a
I'm
radiologist.
married to a radiologist. I understand their thinking.
Is
Actually,
there does she say clinical correlation to everything you do?
they tend to do that kind of stuff, and it's really like, what can they do? They don't really, do the surgery. So that's probably the best sort of statement they can make, basically.
Yeah, I think there's a part of the interventional radiologists. They have a little more of a surgeon attitude, but most of the diagnostic radiologists, they are always talking about clinical correlation.
Yeah.
Which is a term I really hate.
Yeah, that's true.
I don't like it in any kind of situation, whether it's spine or just general radiology. It's kind of like a mealy mouth thing to say, like, oh, I don't really know what it is.
The thing is, with the posterior, people are always concerned, especially if you want to basically fuse multiple levels. They're always worried about their motion, and I always tell patients the majority of your motion is between your skull and the first two vertebrae, which is not
occiput to
usually
C2,
what's
that's right.
which is not usually the areas where we're even in play.
Generally, don't even touch those levels.
Yeah, unless there's some pathology up
It's
there.
rare.
Right, but that's if you're addressing that specific pathology. But usually just for a herniated disc, C3, 4, 4, 5, 5, 6, 6, 7,
The vast majority of their motion is coming from the top three levels, you're right. And by not touching them, they're not going to be affected. They, like Steve, the Uber driver, he was able to go back to becoming an Uber driver after a multi-level C3 to C7 fusion with instrumentation.
Your body
and
adjusts.
No problem. He was fine.
You accommodate to this.
And a lot of these patients who have multi-level degenerative changes, they don't have that good motion in the first place.
Right, the disc disease. They're not even that segment's not even working properly to begin with.
Right, and their motion isn't good to begin with. Ironically, sometimes their motion's better after the surgery because they're not having pain anymore.
Right, that's another thing.
And these studies in orthopedics that compare ranges of motion or comparing it to a normal 21-year-old neck that's totally normal. Of course, it's going to be different from those patients.
Right. I can
But
barely move my neck now.
I wouldn't say you're not an old man yet. No,
I don't know,
no,
man.
you got years to go.
I've been asked already. Do you want your senior citizen discount at the supermarket?
I would take that for sure. No
I
problem.
know. I took it the opposite way.
Yeah,
I was insulted.
I was
I was like, what?
I was at a store
Come on.
recently in Florida, and they and the cashier, I noticed the price was a little less than I expected. I look at it, I said, "Did you make a mistake?" She goes, "Oh no, we applied the senior discount to you."
Really?
And I didn't know whether to be happy about getting the discount or being more upset about the fact that she thought I qualified for
you took the high road. You just said
I took the high road. I said, you know what? Take the
discount.
Take the discount. It's money. A penny saved is a penny earned. So
right. Especially
I was happy.
Especially since you're such a senior. Money is tight.
Yeah. I mean, like when we were younger, you would get fake IDs to get to drink earlier because the drinking age. When I was young,
it was 18. Generally.
It was 18. When I turned 18, it became 19. When I turned 19, it became 21. When I turned 21, I thought it was going to be 25. They kept moving it back every year, and so I was pleased when I was 21 that it stayed drinking age 21. But now you need a fake ID to get the senior discount. Get your AARP card.
You need an AARP card, exactly. And I get all that information in the mail, but you get that after 50, so we're already in that range.
You don't have to. Yeah, I mean it's kind of, and they have these in Florida, these over 55 communities that are kind of nice.
People are pretty. From what I understand, pretty happy there. I couldn't live in that right now in my.
You have young children. You're even though you're over 50, you're kind of like a teenager in some respects. You have two kids. You have one child still in high school.
Yeah.
2 in college. 1 recently graduated. So you're kind of living vicariously through them, which is kind of nice.
Yeah, I guess. But I mean, I don't know.
It keeps you young.
I feel like I'm disturbed all the time, though.
Don't take it too personally. That's just the way it is.
I just want to at this point, I decided instead of getting upset about these things, I just want to laugh. I'll just laugh at something. Like even you say something I don't like, I'll just laugh at it. I'm just going to laugh from now on.
That's a good attitude.
That's all I'm going to. If you say something that's going to make me feel bad,
we can't.
When I was way too much.
When you were overweight, we would make jokes about that.
Right.
Yeah. That was done out of love. That wasn't done out of.
No, I understand. And actually, you know what? I was thinking about it the other day.
It motivated you.
That's the thing about you. You say the truth, and the truth hurts. And the truth.
Sometimes the truth hurts. But it's how you say it. But you can be mean about it too.
But you know what?
Try not to be mean.
Sometimes being that way makes you really do what you have to do.
You have to motivate the person because you care about them.
Right. So I sort of thought, I was thinking about this the other day about you, and I need to just take
a little
things
more relaxed,
a little more light, and things like that.
Don't take it to heart.
Yes,
we mean well.
I know.
We can talk. One thing that comes up with anterior versus posterior is the instrumentation is different. We'll go back to that.
Oh yeah, well
we digress. So when you go from the front, we generally will use a plate with screws.
Right.
Or sometimes we have these new standalone devices that have the screws built into the cage.
They've got all kinds of great new stuff.
And the technology is really advancing. It's much different now than it was 25 years ago when we first started.
I love these new cages because they're made with like all kinds of like porosity. They almost look like a piece of bone.
Yeah.
But they're
the
not.
Orthopedic surgeons found, I think more from like total hips, that you want to have a device that's going to allow for bony ingrowth.
Right.
So there's a whole science to it as to what the ultimate pore size should be of that cage or that hip implant to get the bone to grow into it and really become a part of your body.
And what's great about these cages is that they really give you that initial stability.
Yeah.
That you don't exactly have from a piece of bone. I mean, obviously you open up the space and then you sort of clamp down on the piece of bone afterward. But these cages are really, I think, quite fabulous, and you rely less on the structure of the plate to really keep that. It really load shares well, those cages.
So we use those cages when we go from the front. We kind of shifted now away from just using the bone graft. Although I still like bone on occasion.
Yeah, bones, you can mold it, the way you need it.
Right, you can shape it down to the patient's anatomy better. it's a little more physiologic. Some patients are always worried. What do you think about this idea that patients are worried that they're going to get diseases from the implants? I think that's been
It's not too many people
debunked.
ever really ask. The main thing, people are becoming very savvy these days, and they're chat GPTing everything, they're Googling everything. Particularly, the thing that they ask the most is the next segment failure, next segment degeneration from fusing.
Right. So some surgeons will, when we talk about anterior versus posterior, anteriorly you can also do a disc replacement.
Right. This is what spurred the development of these disc replacements.
Right. And so by preserving the motion at that one level, are you eventually going to prevent the adjacent level from deteriorating as quickly?
Right.
And you're saving them from needing a fusion down the road. I think it's becoming, it was a little more controversial in the past, and there's still some studies that suggest that there's really no difference between going ACDF, which is a fusion of one level,
Right.
versus doing a disc replacement, which is
There's no
which is a little
real
surprising.
clinical, proof that one is better than the other one. The problem is a lot of these patients don't fit the criteria for putting a disc replacement. And they have a lot of degenerative disease, both anterior and posterior.
Especially older patients,
Right.
and especially in the lumbar spine. I think the lumbar spine, isolated disc pathology is so rare.
It's
To
so rare.
Just have a black disc disease, and that's the pain generator, and without having any stenosis or herniation, and you can just go from the front, and that's all. I think that's why those didn't take off like we thought they would.
No. And plus there's also when you instrument in the space, the disc space, you stimulate the bone growth. So
Right.
a lot of these patients end up fusing anyway.
Right. And here's a question: do you think? Right, you mean they're fusing across their disc
You fuse
replacement?
across their disc replacement like any other implant you would put in.
So it's essentially being a fusion.
Right.
Even though they were thinking they were doing a replacement, they ended up really, it turned into a fusion.
I've seen patients come in with a disc replacement with a massive herniated disc above their disc replacement. So they're fused across it because of Wolff's law, and anything, any bone
and
graft under
Wolff's
compression.
law is what every orthopedic surgeon learns as
It's the most important.
as a junior resident, which is bone response to stress.
Right.
So that's why we want patients to get up and put weight on things, and it allows the bone to heal better.
That's right.
In a lot of situations, depending what their problem is. But yeah, Wolff's law is very, very important. So bone response to stress.
Right. But obviously, if something's unstable, you don't want you don't want to move it like a fractured arm. Obviously, you want to stabilize it because it's you could separate the fragments, I suppose.
Right. So what we're talking about generally when we're talking about front and backs is really more for degenerative conditions.
Right.
There are traumatic conditions where you can have like somebody has a diving injury, they have a severe, you can get a burst fracture where you have canal compromise and paralysis, unfortunately. And sometimes they might have a car accident, have jump facets, which is a different problem that you're going to go posteriorly as opposed to a burst fracture where you're going to go anteriorly.
And sometimes you need to go from the front and back for unstable.
And if there's a lot of
segments of the
instability,
spine.
then you probably do need to do a front and back in those kind of situations more than in the degenerative situation. The degenerative is almost like a different problem.
Right. So people come
They're
in.
not as unstable, and they have a lot of degenerative disease to begin with.
Right. Those are separate things that we don't see a lot of because we don't do a lot of trauma.
Right. We
used to do a lot of trauma, but now
I guess now that we're entering the AARP years of our life, we are doing less and less. We're giving the ER to the younger spine, hungrier spine
They're very
surgeons
aggressive and
who
they
like to get up at 2:00 in the morning.
They don't mind operating until 2 a.m.
Sometimes you have no choice but to do it. Yeah,
That's right.
Do you have to do it in the middle of the night if somebody has a burst fracture in the cervical spine and they have
It depends
or
if they're
in the
coming.
lumbar
It depends
spine?
on their neurological status. If they're stable neurologically, you can probably wait till the morning when it's better conditions for the OR, when all the staff is there and things like that that are used to doing spine. But it's rare do you have to really take unless you have a patient who has a massive compression that developed and they have a rapid deterioration, have a Quantis syndrome.
So if they come in and they're neurologically intact and they were in the transport, something happens, the spine shifted, and now they're no longer neurologically intact, you'd be
Right, then you have to
be a little more aggressive,
then you have to
and
deal
the
with
imaging
it.
study shows the change.
Right.
You might want to be like, okay, we gotta act quickly.
That's right. That's right.
In this situation.
But it's kind of at the spine.
rare
Usually you hopefully be able to wait. Hopefully you can get time in the morning to because they'll say, why didn't you do the surgery then? Why not? Why now is it an emergency? Why didn't you do it at 2 a.m? And it was, because you don't want to operate in the middle of the night. We're human beings,
It's never, operating in the middle of the night is never ideal, because
No.
you don't have the right staff. And let's face it, surgeons are human beings. You get
Right.
you get tired. You're not at your best.
I mean, although the adrenaline does flow when you're in the
Flow.
operating room.
And in our training, we did a lot of operations in the middle of the night because
Sure.
we had no choice. That was the nature of the beast at that time.
I used
And
to do tons of
ORs
brain
weren't always
surgery.
available the next day. We had, that now most of the level 1 trauma centers will have a dedicated trauma room that's open 24 hours free. They keep open for those traumas.
Right.
I know Winthrop does that. I know that when I was in Seattle, they started doing that at Harborview. It's become a standard because otherwise it's too disruptive to the OR. You got to bump everybody else's
That's
cases,
right.
and nobody likes being bumped.
No.
So
That's the worst, because then you have to call the surgeon and they get upset because they're all set to go and you're saying, I'm sorry, I have to bump you. And they're not too
Yeah.
happy usually.
I remember when I was first in practice, I was doing hip fractures, and I was at Plainview Hospital at that time. For an assistant, we used to use general surgeons, and so there was an older retired general surgeon who used to be the chief of surgery at Plainview, who was my assistant. And it was a Saturday morning. We were doing 2 or 3 hip fractures, and we get a phone call from the ER that the general surgeon wants to bump our case for an emergency. What do you want to do? I was like, all right, well, I guess we got to be bumped. What do you want me to do? What do you want me to say? So my assistant, Dr. Klein, Maurice Klein, do you know
Oh,
Maurice
I
Klein?
remember him. He was
a tough
great.
guy. So he examines the patient in the emergency room.
He goes and sees
He comes
the
back
patient.
and he says, they are not bumping us. That is not an emergency. It was one of the happiest. I was like, oh, good for you, Maurice. I'm so glad I used you as an assistant.
That's funny.
Yeah, that was a good.
I remember him. He was great.
I hope he's still alive.
I haven't seen him in a long time, but
He's probably retired. Hopefully, he's retired, having a good time in Florida.
yeah, that's where they tend to go. Isn't
That's
it?
God's waiting room.
I don't know. I don't know if that's where I want to end up. That's something I.
Well, hopefully, it's many, many years from now.
No, I know, but a lot of people are going down there. I mean, you certainly can set up a shop anywhere. Be
I have a place down there, but I don't know if I want to work. Yeah. So what was interesting about operating middle of the night, I was thinking about, was that Elon Musk was saying that his new robot technology is going to be so good in the next 10 years that he'll be able to have a robot that will be trained to do surgery without any emotion, without any fear of getting tired, and will be perfect.
I mean, I would love.
That'll be a nice thing.
I would be fascinated to see a robot just make an incision, set up the patient on the table. I mean, how do they?
I don't think that's going to happen.
I don't think that's going to happen.
I think from somebody who hasn't ever been in an operating room, it's a nice thought. But the OR is, like you said, there's a lot more going on in terms of positioning of the patient, in terms of, dealing with the anesthesiologist. There's a lot of factors that are just too complicated.
Maybe the robot will end up being like the assistant in a way.
Robot assistant, or you can guide the hands of the robot like they're doing now with the Da Vinci system in urology and general surgery cases.
I don't know. I mean,
It's hard to do in the spine.
I don't know what kind of things Elon Musk has in mind in the future for their ability to understand how to set up an OR and do a surgery.
He is a genius.
It's going to be really interesting to see what
that will
happens.
change training for generations to come.
I will be.
I mean, have you ever gone to you went to medical school at Jefferson, right? And wasn't there
Temple?
I'm sorry, Temple. And isn't there a medical history museum there?
Oh yes, very famous, the Mutter Museum in Philadelphia.
Museum.
That was a fantastic museum.
And sometimes you look at the tools that they used 100 years ago, and you look at them, and you're like, what kind of people were these? What barbarians?
Especially
they look like ancient medieval torture devices, and this was like a standard operating room 100 years ago, and
they used to wear tuxedos in the operating room.
Tuxedos?
They had no. You see
they didn't wear gloves.
You see the paintings on the wall at Jefferson.
Yes, they were very dressed up.
Mutter Museum. They
yes, it was an event
with their audience.
Was that actually in the operating room? That was like a cadaver lab, like a medical school.
I mean, I think they were perhaps a cadaver. There's a couple famous paintings, especially at
Like showing a human dissection that they were. I think it was more like a medical school. They were showing that,
But they used
like
to just
surgery
be
class.
dressed formally, these people. So if I no gloves,
Yeah, that was. They started wearing gloves because of nurses. The nurse had a problem,
thank God Lister came about,
and they said maybe we should wash our hands before we do this operation.
Yeah.
That helped. That saved a lot of people. Yeah, so maybe in 100 years they'll look back at the things we were doing
Primitive.
with these animals. They were putting in these metal cages and screws and
You
rods
don't have
and
to do that.
plates. You can just put a
you
little
just
injection
squirt
of
some
something
material
and
in there.
we'll make a new disc for them. Well, that's probably the future. Is it instead of a disc replacement, just actually making like taking the patient's own genetic material and forming their own disc, and then you get the disc implanted, your own disc.
That would be pretty amazing.
That would be, the question is, how do you get it to stick? How do you get it to stay there without putting metal in them? Like what?
Well, maybe the disc
you
will have
you have
ability-
to find some kind of a glue or something that will grow the disc into the bony end plates immediately.
What are there's the connection of the disc to the bone itself.
They're like spicules.
They're like little tiny
yeah.
spicules that grow. Look, obviously, who knows what's going to happen in the future with that. People are working on it.
That I think that would be Nobel Prize winning if you can reverse the aging process and be able to replace people's discs or the cartilage in their knees.
Cartilage is the thing.
And really disc material is almost the same as cartilage.
It's cartilage.
It's a form of cartilage.
Different types of cartilage.
Yeah, and we know because we operate in young and old patients, and young patients have very nice, soft, supple disc, and it's a pleasure. And then older patients are much more degenerated. They're collapsed. They lose their integrity of the disc, and it's just not the same. And then that leads to a whole series of cascade of degeneration that leads to stenosis and pinching of the nerves and radiculopathy and pain.
I always tell
stiffness.
patients that arthritis is just a response of the body to instability, and that's really what it is. I mean,
There's usually some kind of an injury to that disc or that cartilage, which starts the process of degeneration, and then your body tries to stabilize itself.
That's right. And these things that are made, this arthritis that is made, is just a response to instability. But in doing so, the nerves become collateral damage.
Yeah,
because they get compressed upon.
Because they're sharing the same space, and the space gets pinched.
Right.
That foramen, that hole that the nerve goes through, gets smaller and smaller.
Because the spine doesn't care about the nerves. It's taking
it
care of its own.
itself. It just wants to,
just wants to stabilize
selfish.
itself. That's all it's trying to do.
that is true.
That's how I look at it. And that's why I tell patients, how to look at it.
That's how we evolved. Because before there were spine surgeons, people were getting back injuries, millions of years ago, running away from animals and
that's right.
Being in the doing what they needed to do to stay alive, and they were aging also. So there was degeneration, and there was no MRI, no CAT scan.
But they didn't age as much because
maybe they didn't live as long.
They didn't live as long.
Well, they were done. Well, if you had if you got appendicitis at 15, you were a goner.
Right.
That was it. There was no.
But that's the question: is when you think about how long did people live then, like till 30, 40 at most, or 35? You didn't have enough time to develop some of the changes that we now see because people are living longer and longer, and we were now starting to work on patients in their 80s because they're in such
90s.
good shape.
I've operated on somebody over. I do a lot of kyphoplasties. I've operated on people over 100.
Well, that's a kyphoplasty. That's sort
a
of
simple operation.
That's a needle stick. We're talking about doing. We did a recent laminectomy on a lady who was 85. And I was like, really? We're going to do this? But, we did it, and
she was a Holocaust survivor, and she actually did quite well.
She did well.
And, she had been turned away by a number of different spine surgeons, and I felt bad for her. And she was actually a good patient. She was relatively healthy for her age. She had some hypertension, but otherwise she wasn't in bad shape. And she was very active. She was living independently. You gotta take a look at the whole picture. There are some 80-year-olds that are like youngish, like in their 60s, and you have some 50-year-olds who are like 75.
Absolutely, just really, on.
What do you think? What do you think ages you the most? I think smoking and drinking. Sun exposure makes you look older.
Certainly, all those factors are huge, and
there's a factor of genetics.
I think just exercise is so important. I think drinking.
Sometimes you see somebody think they had a hard life. You know, they're like 55, 60 years old, and they look older than, you know, the line in medicine, they look older than their stated age.
Right.
That's never a good thing.
Because they abused their body when they were young.
They
That
had a
was the
hard
thing.
life. You know, they're in the sun. They were smoking. Back in the '60s, maybe not the '60s, but maybe I don't know. In Vietnam, did they give rations of cigarettes when they were in the war? I mean, they did in World
I'm
War
sure
II.
it was just everything was
It was
readily
part of like
available.
he was like, here, have some cigarettes that'll calm you down,
Nobody knew it was bad for
and
you.
they all got addicted. You know, and I
Nobody knew.
remember when I first started, there were surgeons who would smoke. You don't see that often
There
now.
was smoke in the not in the OR, but they would be smoking around the OR, outside the OR.
There were I remember studying. There were anesthesiologists in Italy who were smoking during the operations in the OR
Well, that's
with the oxygen tanks right there. I mean,
Well,
that was probably a big no-no.
they knew how far to
Socialized
stand away
medicine.
from them.
You can do whatever you want. I'm going to smoke in the OR.
I remember one of the most famous neurosurgeons, Harvey Cushing.
Sure.
He had to have a cigarette after every case.
Smoked?
He smoked.
Where was Harvey Cushing at?
He was at the Brigham,
The Brigham Harvard.
and he always drew the pathology that he just encountered in the operating room. He made a sketch of
Wow.
what he encountered and a little journal
Those
entry. of what
those
he
guys
did.
were legendary.
They were legendary.
I mean, who does that nowadays? Draw a sketch.
You just can't get. We can't wait to just go.
Can't
home.
wait to get out.
Exactly.
You know, we're looking forward to
Smoke that cigarette. But it's a.
I guess we don't smoke that cigarette. Maybe we should start smoking a cigarette after the
It's
case.
very satisfying. It's like for them, it's like having sex. So therefore, like they smoke a cigarette afterward. That kind of
I
feeling.
never got that. That's to calm them down after the act.
Right. Exactly.
Whether it's operating or having sex, it's the same
It's the
idea.
same feeling of as Dr. Greenberg, the legendary founder of our practice.
He used to operate at Winthrop.
He operated. I remember one of the nurses said he just stopped in the middle of operating. He said, "Damn, I love surgery."
Yeah, Patty Cantreva. She was great.
Yeah.
It's true.
We got to get a nurse to come on board. We've been trying to get nurses to come.
I think that's a good idea. We can get a nurse, maybe we can get a circulator nurse and a scrub nurse.
I mean, just to hear from their perspective
Scrub
and how
tech.
they feel about the surgeons. What do they really think of us?
They probably have a lot of stories to tell.
Oh yeah, great
You know.
stories. Some of the older nurses have really been around for a while.
Yeah, no, and especially the older nurses, they saw a lot of change. It's different now than it was 25 years ago, for sure.
There's a lot of guests I still want to get on our show. We want to get I want to get neurologists. I want to get pain management. I want to get
Sure.
nurses. These are the people I still
Yeah,
want to
more.
get.
I think patients I think the public likes to hear about our patient experiences because sometimes those can be very
Oh,
interesting.
the patient experiences are
and
are
that's what,
fantastic.
especially when a patient has that problem, they want to hear another like a lie. Like it's one thing when you hear your surgeon say, "Oh, you'll be fine. You'll be in the recovery room for a couple hours, and you go to the floor." Hospital for a few days and you'll be fine. In a few months you'll be back to your regular activities. And then you have a real patient telling what really happens because the internet is such a dangerous thing. People hear both good and bad, but a lot of it's more because bad stuff sells. So a lot of what they hear on the internet is really bad.
Oh yeah, I mean everybody thinks they're going to be paralyzed from having low back surgery, and I say to them, where we're working is below the spinal cord. Most people don't even know that the spinal cord ends at the upper lumbar. They think it just continues all the way down to the tailbone.
And they hear the word fusion, they want to run away.
And I tell them the fusion is the fun part of the surgery.
It's fun for us.
I said the art of the surgery is making sure we get a good decompression and get those nerves decompressed.
But I think one reason why spine surgery generally has a bad reputation is from the past when they would just do, partial operations, like doing a decompression without doing a fusion, and then they would fail.
Right.
And they had a spondylolisthesis, and they just did like a laminectomy at L4-5, and then the spondy got worse. They needed a big operation, and then they got, and of course, when you have a second operation, there's more risk of infection, there's more risk of a CSF leak, spinal fluid leak.
That's right.
More complications. So then things go downhill. So I think you're better off doing it right the first time.
That's what Cloward, the famous spine surgeon, used to always advocate the fact.
He was also from Harvard.
That these people just a lot of them came from Harvard. It's a good place.
Yes.
I mean, I think it's still pretty good. But the surgeon had said that a lot of these patients from the initial start shouldn't have just had a discectomy. They should have had a fusion from the beginning. because
Yeah.
the recurrence or because of just chronic instability and back pain.
Yeah, I think the data definitely show that if you have certain conditions, or if you're going to cause iatrogenic instability, meaning that by doing the decompression, by removing a certain amount of bone on the facet joint, it's been especially in the lower back, you can make the spine unstable. And once you do that, you're almost obligated to do a fusion.
That's right.
You know, and that brings us back to what we were talking about in the beginning with, front or back and the neck. By doing a laminectomy, you don't just do a standalone laminectomy because you make them unstable, really. By
Right.
doing that, and they're going to lose their lordosis, and they're going to become more kyphotic, and they're going to develop deformity, neck pain, neurological injury can happen as well from that if it's really severe, and so you're better off doing a fusion. How about cervical laminoplasty? Do you remember doing
I
those
used to
things?
do those when I was a fellow. I thought it was torturous because what you had to do, at least in those days, we didn't have obviously we didn't have the same technology as they do now, but it's still very similar. You had to put these little tiny mini plates on, um, in basically the remnant of the bone that you've now sort of reflected off the spinal
Right.
cord.
You were doing you were opening the door of the lamina. They
Right,
call
but
it
you were
open door laminoplasty. That the peeling the lamina back, but to keep that lamina
you had to
spread
you had to
apart,
connect the
you would
two.
either put
You had to bridge it.
a bridge it with either a plate or a small piece of bone.
And they're not. It's not that easy to put a plate on when
No,
it's not as rigid as it is when it's not sort of green
not
sticked.
right. It's kind of flapping.
It's not so easy and it's tedious.
It was popularized in Japan, I think,
Right, and I'm not so
because of
sure.
the OPLL problem.
Right, because those patients just couldn't go from the front. But I have to say, I mean, when you do a very good decompression of the spine, I mean, nothing is better for decompressing the spinal cord than a good wide laminectomy in the neck.
I would agree. I would agree that laminoplasty is something that I did as a resident. I didn't really do it as a fellow, and
And I'd be
you
afraid
get, you get a much better decompression with a full laminectomy and then with a fusion.
And I'd be afraid, like, if you lose the laminoplasty, for instance,
Right?
you know,
Can that collapse
can
into the
that
canal?
right? If the mini plate fails, or something like that, then could you reestablish
nose.
compression?
Yeah, yeah. I think that's kind of fallen by the wayside. Not too many spine surgeons are doing laminoplasties in the New York area these days, as far as I know.
Right. But there are some, and some people will convince the patient that this is the better surgery for their problem. So, look, I think you just have to
Because they
stick.
want to avoid a fusion.
Right. Everybody wants to avoid a fusion. That's pretty
But
much the name
sometimes a
of the
fusion
game.
isn't so bad.
I think sometimes fusion really is very helpful to patients.
Yeah, we have to get a better marketer, to name it something else. How about stabilization?
Well, people think it's like some sort of nuclear fusion when you tell about fusion. It's just a scary
They just
word
they
to
just
them.
think, oh, I don't want to have a fusion because I think a lot of them associate fusion with metal, which
Yes,
isn't always the case.
and we
in
don't
the lower
always
back.
use metal
You
for
don't need to,
fusions.
I mean, back in the, back in the days of the giants, Cushing and Cloward and those, there was no metal. Everything, they were doing some fusion at
Metal's
the
a
time.
relatively new thing,
I mean, they were putting people in full body casts and putting bone graft down, and it's really a much more recent phenomenon. In the last 50 years, that metal's become a more major player in orthopedics and spine
I
surgery.
mean, pedicle screws. When did they come out? 95, pretty much.
Yeah, I mean, they were doing them before that, but it was off-label usage.
Right.
You
Remember, we
know,
had to call it off-label usage.
it was
Now it's
off-label, right?
standard.
Now it's kind of the standard of care.
Right.
Yeah.
It used to be only for specific conditions you could justify it or something like that. Or FDA approved for this particular type of
Right, for
pathology.
spondylolisthesis.
Grade 3 spondylolisthesis, or very
Yeah,
rare
and
for
now,
us
and
to
now
see.
there are they're really talented scoliosis surgeons putting in pedicle screws all the way up and down the entire spine. And
Well, they have
thoracic
navigation
spine.
now, and they
And they have,
do it
and
freely.
they call it a robot, the navigation. But is it really a robot?
Well, it's sort
It's
of
a computer guided navigation that helps you in real time know where the screw is going in a 3D fashion.
I mean, you don't have a robot literally putting the screw in for you. You're just guiding the trajectory now with the navigation. You look
you
at
have-
a screen and you see where you're pointing at, and it basically tells you you're pointing that direction, and you can now then check your screws in real time to see if you were completely in the bone and did not for instance, breach the
Right. You still have to know your
segment.
anatomy, though.
Oh yeah,
You can't just rely completely on the technology because if they're off by a few millimeters, that could be a difference between a spinal cord injury and
that's right.
and putting the screw in the wrong place versus in the right place. So millimeters matter. That's why I think the robotic and navigation systems are still a little delayed in spine as opposed to some other fields of
Well, the
of,
brain
of
is used
surgery.
all the time now.
They use it all the time for because I guess the brain is is it more forgivable?
The brain is a bit more forgivable. I mean, we have less. I always tell my partners, spine surgery is a lot harder than brain surgery. It is harder.
Like who would think that? You would think the brain is harder than the spine.
It's not because the brain is big. You have a big space. You can work with the brain. You can touch the brain. You can move the brain a little bit. You can. I mean, I have to say, I mean, you get away with a lot in the brain because it's just there's a degree of plasticity of the brain.
Right, and they say that people only use 10% of their brains, and they're pretty okay. But that's not why the brain is easier to touch. That was kind of a little joke.
I mean, I think that just thinking about like how little room and space we have, and when we work in the spine, um, and you and I when we work together, I mean, we're literally just sometimes we just take off like even to take off a little piece of arthritis that's sticking in, you have very little room of error,
There's very little room for error,
and you have a millimeter
and there's danger because there's
because
the
you're worried
dura
about
underneath
leaking.
it.
You
Yeah.
don't have a. That's another thing about brain surgery is that you're not worried so much about leaking because when post-operatively you can't always get a perfect seal of the membrane after
But
you've
there
done the
is
surgery.
there is CSF around the brain too.
Right, but you don't get these horrible like where you have to always go back to the OR if the person is having some. It'll collect, for instance, under the
Do they do
skin.
a shunt automatically?
No, you just
It will
basically.
seal itself. There's less gravity.
But well, it's just that you don't have the same pressure head because it's not obviously the lumbar versus the brain. But if the fluid seeps out, it collects under the skin. People will have a collection, for instance. You can basically do things to not have to go back to the operating room to reseal it. You can wrap the head. You can tap the collection. And then oftentimes it scars away and goes away.
It goes away by itself.
So you don't have that same sort of hype about when there's a fluid collection from the spinal fluid as there is in the spine versus the
Usually
head.
the spine it's more symptomatic too. They get bad headaches.
They get headaches. They can't move.
stand. They can't. You're afraid of meningitis, so you're really almost obligated to act.
They're miserable.
They can't tolerate the light. They almost get like meningitis type symptoms.
Right. You always worry about that, but I mean, there are certain instances where you have to deal with it in the brain, obviously, particularly when we operate on the posterior fossa, like for like a Chiari or something like that. Those patients tend to be more symptomatic, but the supratentorial stuff, the brain tumors, things like that, resections, you have a lot more leeway up there, and that's one of the reasons why.
So you picked the more difficult field. Spine surgery is.
I think spine surgery. I think it's more challenging in a lot of ways. Brain surgery is like, okay, you have a brain tumor, you have to take out that tumor.
Yeah, but if you were to survey neurosurgeons, would they agree with you?
I think so.
Really?
I really do
That's a
think
shocker.
that. I know. I think that but obviously I respect the brain surgeons. The ones that devote their times to just doing brain surgery. There's a lot of considerations.
I think most neurosurgeons would say that aneurysm surgery is probably very difficult and stressful.
I think when I was trained, that was probably the most stressful thing. The thing about brain surgery afterward, you have to worry about, it's not spine. You can let ooze occur. You have drains in the brain. You can't have blood accumulate because
Right.
it'll press on
pressure.
because it'll press on the brain and cause brain pressure and cause symptoms.
Right.
Spine, it's rare to really get a blood clot that's so symptomatic that you have to take to the operating room again.
But is it an expectation game that like people go in for spine surgery, they expect to come out perfect, and when you go in for a brain surgery, you don't you'll be happy to come out decent, but you think you're going to be a vegetable.
I think that,
and so you're happy when you're okay.
I'm not as certain these days. I think people have pretty high expectations either way these days.
On brain and everything is you want excellent results.
That's right. I think, but I think that you
rightly
can
so.
make an argument for certain conditions of the brain that, there's a possibility that things might not go well.
Well, the things I like, like everything, it depends on that specific situation. What's the location of the lesion?
But if you have a
How are you going to
herniated
get to it?
disc, like on the lumbar spine, young person coming in, I mean, they expect to come out pretty good,
And they generally do.
right? And they generally do.
I would say vast majority,
Yeah.
over 90% will come out great. And the interesting thing is a lot of people who have a herniated disc, an operation is the last thing.
That's right. We're
Most
very
of them
conservative.
get better without doing surgery. 90% will probably get better
Well, maybe that's something we could talk about, next time. Is
without needing surgery. That's
not-
why we had the physical therapist and the chiropractor before. Those were good too.
I think it's good to talk about the things that we don't just operate on every patient we see. We conservatively manage their pain and their problems.
No, I'd say probably 5 to 10% of the patients I see become surgical candidates.
That's pretty much what it is, I
Yeah.
think.
In a good practice, but that's about right.
Anyway, good speaking today.
Are we done?
Yeah, I think we're done.
Okay, you got to run.
I think that, I think that we covered some good topics. Let's continue to do so, and we'll see you next time. Maybe perhaps I'll have a guest.
We will aim to have a guest, and if we don't, we'll be happy to just
Happy to just talk
alone.
about
We can do it.
what we want to talk about.
We're fine.